Hi, my name is Nikhil Srivalsan, and I'm excited to share to you my project about evaluating the predictive validity and discriminatory power of clinical risk scores for recurrent cerebrovascular events using routinely collected stroke and TIA patient data. For today's presentation, I'll begin by going through background and objectives, followed by research methods, key findings, and conclusions and impact. Stroke remains one of the leading causes of death and disability worldwide. Even after initial recovery, about 1 in 4 stroke survivors will experience another stroke, often with worse outcomes. Preventing these recurrences is critical for preserving quality of life and reducing healthcare burden. Over the years, several clinical risk scores like the ABCD, SPI, ESRS, and ROE90 have been developed to estimate a patient's risk of having another stroke. But here's a challenge. Most of these scores were designed years ago using highly controlled data sets, not the real-world electronic health record data we rely on in current clinical practice. So the question we asked was, how well do these commonly used risk scores actually perform when applied to real-world stroke and TIA data? Our objective was to assess the accuracy and feasibility of 8 stroke recurrence risk scores using Alberta's routinely collected data. We hypothesized that while all scores would show some predictive value, their ability to discriminate between patients who do and do not experience recurrence would be modest, with certain tools like the ESRS and SPI-I performing better due to their broader inclusion of vascular risk factors. We analyzed data from 1,799 consecutive patients who presented with stroke or transient ischemic attack across Alberta between 2016 and 2017, with follow-up extending to 2022. Clinical data such as demographics, comorbidities, and imaging were extracted from Alberta's electronic health records, including discharge summaries and imaging reports. We coded each risk score its data and computed its predicted performance using several statistical measures. ROC curves and area under the curve values for discrimination, where an AUC value of 0.5 means no better than chance and 1 means perfect prediction. Logistic regression for associations with occurrence, and lastly, positive and negative predictive values to assess clinical usefulness. This approach required substantial independence, from constructing variables to programming each score's algorithm, ensuring compatibility with our real-world EHR data. Our cohort was representative of Alberta's overall stroke and TIA population. The median age was 70, 78% had ischemic stroke, and 17.7% experienced a recurrence within 5 years. We found that AUC values range from 0.551 to 0.607, reflecting modest discrimination, with ESRS and SPI-I emerging as top performers with AUCs of 0.607 and 604 respectively. On the other hand, ABCD-based scores originally designed for short-term prediction performed less effectively in long-term data with an AUC of 0.551. All scores had high NPVs greater than 89%, but low PPVs, meaning they ruled out recurrence better than identifying it. Interestingly, ABCD3I was the most feasible to calculate from routine data, whereas RRE90 required imaging and stroke subtype classifications that weren't consistently available. This analysis really emphasized to me how models that perform well in control settings can behave quite differently with real-world data. These findings have important real-world implications. They suggest that current clinical scores, while statistically significant, are limited in precision and personalization. 3 key limitations: static designs that ignore evolving risk factors, limited mechanistic insight, and underuse of imaging features. In today's data-driven healthcare system, there's growing potential to bridge clinical data with imaging and machine learning to improve stroke risk stratification, something our team is already moving toward. Moving forward, our lab is expanding the study using ConnectCare, Alberta's province-wide electronic health record system, to analyze a larger and more representative sample. We also plan to integrate radiology features and develop a machine learning model to optimize recurrent stroke prediction. The ultimate conclusion is that existing stroke recurrence risk scores demonstrate limited discriminatory ability, but high negative predictive values suggest these tools may be most valuable for identifying lower risk patients. Overall, this project deepened my interest in translating data-driven research into real-world solutions that directly improve patient outcomes. I'd like to thank Dr. Arvind Ganesh and Dr. Mohammed Al-Muklafi for their mentorship, along with the Calgary Stroke Program and the MSI Foundation for supporting this project. Thank you for taking the time to listen and for advancing stroke care. Thank you.